Next on the lineup is going to be your IVs, PVACs or PVADs, and central lines. This is exclusively the pink packet. And it's got a lot of good stuff on it. We're going to put little extra notes on it. If you turn, the first section I want you to go to, because we're not doing a hematology lecture, I want you to go to where this says Venipuncture. So you see it says aplastic anemia at the top of the second page, everybody? Okay, if you go down that page, we got some holy hookup here. Okay, I've got some things we've got to get to you real quick about venipuncture. I highlighted and made it real bold for you. How many sticks do you get? 2. How many of you have seen people stick folks 6, 7, 8 times? Don't you dare let me hear that you did that. Now, I'm one of the best. I'm so good, anesthesia has called me to help them. But I have never, nor would I ever, stick somebody more than twice. It doesn't stand up in court. You look like a fool when you damage their nerve. You cannot stick people more than twice. You can't do it because every time you do it, you think you got it. Now you think you got it for the 4th time. Now you think you got it for the 5th time. No, it's not worth it. Just 2 times. Please hear me on that, because that's a big legal issue. Okay? Do not stick people more than twice. And you want to document it. Okay? Unsuccessful venipuncture. And you do it twice. You just cover yourself nicely there. Okay? Now, don't be dingy. You do have to try twice. Oh, I just got out of school yesterday. I'm scared. I passed my test last week. I don't know if I can do this. Oh, my God. I don't want to do it. Oh, you better do it, because how you going to learn? So one of my nurses sent me an inbox. She said, I need your opinion. Did I screw up big time? Because I think I made somebody really mad. And she did screw up big time, and she did make somebody really mad. She said, I know that I'm not good with IVs. I remember I'm really bad at them. Plus, you know, I just passed my test 2 weeks ago, and this admission came in on evenings. He was really hypovolemic, and he was dehydrated, and it was long-term care, and, you know, there's nobody else there very much so. So she says, I didn't want to blow his only veins, so I only tried once. Wrong answer. You don't have a choice on this. You have to try at least twice. So when the next shift came in and she gave them that crazy-ass report, that nurse looked at her and said, I guess you better get your ass in there and try again. She was like, oh, my God, I know I'm not good at this. I don't care what you're not good at. You ain't poking twice. You can't talk to me. That nurse was right. That nurse is right. You have to try twice because you can't get good if you don't try. Yes, your patient's at risk because, you know you're going to miss. But it is what it is, you guys. You can't get good at it unless you try. So you can't try more than twice, but you better have tried twice. Okay, that's just real. In your real life, you better make sure you got 2 pokes. Okay? Now, you got a little bit of important shit here. Number 1, make sure you write 15-degree angle. Make sure you know that we don't like to draw any blood from an IV site. So if we're going to do a venipuncture for a blood draw, we don't like to draw blood from an IV site. Can you avoid it? Well, let me correct that because it's confusing to students. Let me correct that. When I start the IV, I get blood at that time. Now that the IV is already in the arm, if I have to draw blood, I go to the other arm. Does that help a little bit? Now, sometimes, a lot of times, your patient got an IV in each arm. So now what do? Well, remember it like this. You can only draw blood below the IV. You can't come above it. That's why we don't like to put things in the hands, and we like to go up the arm more, because we can, if we have an IV here, in the cephalic vein going up and around, if we have an IV here, we could do a venipuncture down here, But it's really not a good idea to go above the IV site ever. So I'm going to say that again because it's important. Never draw blood above the IV site. Never draw blood above the IV site. Only below. Okay? Now, giving you more little tips. Do you see where it says IV meds push slow to avoid hypotensive reaction? Everybody see that? Take that real serious. What was the only medication you could push super fast? Adenosine. Okay, so make sure you know that. Adenosine is the only medication you could push super fast. Everything else, I don't play with this. I go real slow, especially morphine. Adenosine has a short half-life. But every other drug, I push very slow, especially morphine. Dilaudid, all of that, real slow, okay? Something else on that issue. Never, ever push potassium IV, right? You don't ever give potassium IV push, ever. Okay? No LPNs is doing IV push. Nobody's doing that. What is that? That's crazy. And you know, I stand up here talking all kind of shit to y'all, and y'all be looking at me like, okay, Shelby, whatever. But we were just in class the other day, and the gentleman said his friend at work, the resident told him to push potassium IV push. Who was here that day? You remember? Okay. And what did the nurse do? She basically told him, go to hell. I mean, you know what I'm saying. She didn't say go to hell. But she told him, are you crazy? I'm not doing that. And he ended up getting chewed a new butt with his senior resident, right? And the senior resident told the nurse, good job. Excellent. Someone else might have done it. Then the resident himself, of course, a day later, came back and said, thank you for stopping me. I had no idea of the risk. You are the patient advocate. You are the stopgate between life and death and disability. You can't do what you're ordered to do. You got to do what you know how to do. And you know better than to push potassium IV push. I'll be damned. He said, push it. This was not that long ago. Okay? Now, some more things about potassium. Just because you know that damn drug is deadly. No more than 10 milliequivalents over 1 hour in a piggyback. No more than 10 milliequivalents over 1 hour in an IV piggyback. No more than 40 milliequivalents in an IV infusion. So that's where you have 1,000 cc's and you put in 40 milliequivalents. No more than 40 in an IV infusion for peripheral line. Regular routine IV, no more than 40. No more than 80 in a central line. No more than 80 milliequivalents in a central line. Use a pump 100% of the time. Use a pump 100% of the time. All right. Now I want to point out to you that for your exam, you may have different language. They're never going to say peripheral IV. They're going to say either peripheral vascular access catheter or peripheral vascular access device. No both. An IV is that, PVAD or PVAC. That's your peripheral IV. And that messes a lot of you up. I've had people say, I thought it was the ventricular assist device, because at your job you work somewhere where we say VAD this and VAD that and LVAD this and RVAD that. And you're used to VAD as a definition, but that VAD, no, that's an IV. You gotta really read it. Okay, this is why we tell you to read every question twice. Okay, now, if you move to the next page, you'll see it says IV bags, IV tubing, blah, blah, blah. And I wrote something in really big capital letters. Does everybody see that? What did I say you need to do? Big capital letters. Check IV site every hour. What's the most important thing you're watching that site for? Oozing. Good answer. It's right next to it. Oozing. What is oozing at the IV site the first sign of? DIC. DIC, low platelets, thrombocytopenia. Man, you better watch it. I picked up on it immediately with my papa when he was getting chemotherapy. And I thank God I did, because we saved his life. Had I not been there to pick up on that oozing at the IV site, he'd be dead today. The nurse was not on the game as much as she could have been, but she was a good nurse, but she just wasn't that tight with it. So y'all ain't going to be stupid. Y'all going to go out here and be looking at that IV for oozing at the IV site. Okay, so OMG, I wrote that. Now, 3 things. You have, of course, phlebitis, infiltration, extravasation. What I wanted you to notice is I included extravasation with infiltration. There is no way you can have extravasation without infiltration, because by definition, it's leaking of a vesicant drug around the vessel. So I'm going to make that plain again. I'm trying to hook you up. Extravasation is a type of infiltration, but it's infiltration of a vesicant drug. So all extravasation is an infiltration. All infiltration is not an extravasation. The only time we have an extravasation is when you have leaking of a vesicant drug around the vessel. Now, I put in big capital letters 2 big differences. The first one for phlebitis, and by the way, nurses screw this up all the time. They screw it up all the time. For phlebitis, I gave you the capital word, the capital letters warm. Does everybody see that? Warm compresses. Capital letters. For infiltration, I gave you the capital letters of cool. Again, nurses screw this up all the time. Let me explain to you why you won't be that nurse. When you talk about phlebitis, phlebitis is inflammation but not infection. Inflammation of the vein, usually due to trauma from the needle, but it could also be due to a bunch of other things. But it's usually trauma, okay? Here's our problem. When you have inflammation, you have an activation of platelets. When you have an activation of platelets, you can get a clot. Do we all agree? Okay. If you give warm compresses, you create vasodilation and you allow for the blood to move through that inflamed vein better and not get stuck and clot. If you crazy and don't know what the hell you're doing, and you put cool compresses, you increase the risk of a thrombophlebitis, which is a clot at the site of the IV. So you have to have rationales. Many of you, you go to toe-to-toe. I say, what's your rationale? You got to tell me why it's better to do warm than cold. Because without a rationale, you don't tend to comply or even understand or remember. If you're just doing memorization, you don't have a rationale. Oh, was it cold? Was it hot? What was it? I don't know. Eeny, meeny, miny, moe, page 4 on my notes. I think it was cool. No, you have to have a rationale for everything you do. Okay? Now, so infiltration, on the other hand, it's going to be cool because it's swelling of tissue, and edema responds very well to that, and it's going to feel better. So you want to remember these things. Can you do warm with infiltration? Sure. But you can't do cool with phlebitis. You can't do that. Now, let's give you some little hookups. Under phlebitis, we have to give you some really key terms. First of all, the signs and symptoms of phlebitis equals straw. So straw is easy. Everybody knows what straw is. And for shits, kicks, and giggles, just in case somebody don't know what straw is, what is straw? Swelling, tender, red, warm. Good. Okay? All right, so that's straw. That's what phlebitis is. In addition to that, highlight palpable cord, rope, red streaks along the catheter, and sluggish. Okay? For infiltration, some classics with this one, you want to highlight cool, pale, or mottled skin with blanching. And no blood return. Okay? Now, the next section you see is isotonic, hypotonic, and hypertonic solutions. For this, I want you to write certain areas that you would use these fluids in. For isotonic, this is again maternity, surgery, the emergency room, so trauma. Basically, anybody you would have gave blood to needs isotonic fluids, okay? So surgery, maternity, operating room, emergency room, those are all isotonics. Hypotonic, keeping it all the way real, rare. I don't give it as much, and maybe on, an obscure test here and there, but I don't give it as much. I rarely do. Hypertonic, oh yeah, neuro patients. Cerebral edema, ICP issues, big time. As you know, 3% sodium chloride is for SIADH. Question, everyone. Is that hypo or hypernatremia? Hypo. Because remember, everyone, that SIADH is another word for hyponatremia. Just trying to hook you up on your endocrine. It's another word for it. Okay. Yep. Midlines. Midlines are not central lines. Look at what I wrote. I wrote that in capital letters. I wrote not a CVC. CVC, central venous catheter, not a central line. On exams, it may not say central line. It may say central venous catheter or central venous access device. It is absolutely not a central line. Why? Because with central lines, the tip sits in the vena cava. With this, the tip sits in the axillary vein. This one, the tip sits in the axillary vein. Now, we love them. We love these IVs. They're used in long-term care, especially when a patient's been ordered 10 to 14 days of antibiotics, the way you do with osteomyelitis. So anytime I need an IV longer than, like 7 days or whatever, or more, obviously more than 72 or 96 hours, because remember, everyone, the peripheral IV, you have to start a new one after 3 or 4 days. Some institutions say 72 hours, some say 96. And you mad too, because you're the one that put that IV in there, and that was a good IV. And the thought of you having to take that good IV out and do another one, you are mad. But why are we doing that? Infection. So it's a foreign object in your body. It's going to set up an infection. So your institution may say 96 hours. Some institutions say 72. My entire life, it's been 72 hours. So I just roll with the 3-day rule on IVs. This is why you have to date them. Okay? So a midline is so wonderful because look how long it's going to last for a while. Look how long it's going to last. Usually a month or 2. Y'all see that? That's what's up. Who wants to get poked again and again and again? It provides for better dilution, but you still cannot give vesicant drugs. Now, what the hell is a vesicant drug? Pay attention to this. A vesicant drug, which is what I wrote under midlines, are drugs, everybody follow with me, that has a pH less than 5 or greater than 9 or an osmolarity greater than what? 500. Okay, so you still can't give that through that line. You don't want to give those kind of drugs through a regular IV. Those are central line drugs. Anybody can put in a midline, a doctor, a nurse, blah, blah, blah. X-ray is not needed. Oh, we might want to put stars around that. X-ray confirmation, not needed. Whew, okay, look at what you got, babies. Now, here's the thing, don't be dingy. Do you have a risk of a pneumothorax with a Piccs line? Do you have a risk of a pneumothorax with a Piccs line? Nah. This is what I want you to pay attention to. I want you first. The only... Okay, so let's not get this twisted, okay? Shit is important. Here we go. If anything happens throughout the thoracic cavity, surgery, insertions, biopsies, centesis, so what I say, cabbage, thoracotomy, thoracentesis, subclavian insertion of a central line, pneumonectomy, lobectomy, car accident, airbag, all that happens in the thoracic cavity, doesn't it? That's when you're at risk for pneumothorax. This Piccs line is over here. How are you at risk for a pneumothorax? You're not. You are if I'm inserting a subclavian. So subclavian is in the thoracic cavity. If I'm doing a liver biopsy, that's the thoracic cavity. All of those things put you at risk for a pneumothorax, which means you, my love, have chest tubes at the bedside. So if we're going to do a central line insertion, as you can see here, I put it in the actual packet for you. Again, this packet is very comprehensive. I put there, have chest tubes at the bedside for insertion due to risk of pneumothorax. You need to make sure you write only with subclavian. Remember we said we could get a bloodstream infection, which is called BSI, everybody remember? Now, a lot of times your institutions will have their little rules about when to change the dressing. And I'm still at the central line section of your pink packet. A lot of times your institution will have when should you change the dressing. But what if they don't? This is why you had to know the ultimate when to try and change the dressing rule. And it is different per central line. But in general, look what I wrote. Change the dressing every 48 hours or with what? Any soiling. When you change the dressing, what do you have to do, y'all? It's in bold print. Both you and the patient have to wear a mask and a bonnet. Both you and the patient has to wear a mask and a bonnet. Okay, so let's look at some more aseptic technique stuff. If you go down a little bit, you'll see where I put scrub the hub. Everybody see scrub the hub? It's kind of critical. You're scrubbing the hub for 15 seconds. We usually use a bio patch. It has to come into 360-degree contact with the catheter, so all the way around the catheter. It's underneath the actual dressing or op site, and it has chlorhexidine. You kind of care about that. I want you to put a little something underneath that. The word septicemia. This patient is going to have septicemia from this doggone central line if you don't maintain a septic technique. How does that look in a patient? Well, you know, fever, chills, tachycardia, low blood pressure, basically septic shock, but not quite. Okay. Now, if you go up a little bit, we have a very major risk with the central line of an air embolism. This air embolism is going to occur if air gets in the central line. And if you work in ICU right out of school, which many of you will, you'll work right in ICU right after school. You are bubble phobic. It's kind of comical because if we take an ICU nurse and put her on the floor, we're going to have to deprogram her for 2 years about bubbles. Because a bubble in a peripheral line is not going to do nothing to you. But she's going to freak out because she's so trained to look for bubbles in the ICU because those could kill her patient with an air embolism. Because where does the tip sit with this damn bubble? In your heart. So let's just make sure we got it together, okay? Let's travel with the bubble. Bubble entered into the central line. The central line tip is in the superior vena cava, or if it's in the femoral site, which is our last resort, it's going to be in the inferior vena cava. Either way, it's in your heart. Let's go on and travel with the bubble. Where the bubble going, y'all, after the superior vena cava? Where is it going? Right atrium. Then where is it going? I'm looking over here. This table better talk shit. What you say, sugar? Try it before you buy it. Tricuspid valve. Where is it going next? I'm looking at this child. Wake your ass up, party animal. Where is it going? Got her eyelashes on, though. She cute. Right atrium, tricuspid, then what? Try it before you buy it. You done went all the way on the other side of the heart?
Oh, I skipped it.
You skipped a whole lot of shit. Where is it going, Sharika? She's still asleep. Thank you, sugar. Right ventricle. Where is it going after that, Miss Dana? Like she's still asleep too. Okay, boo-boo kitty. Where is it going after that? Crazy ass kids. Where is it going? Where the hell is it going, boo? Oh, thank you, Jesus. This child did not get high yesterday or party. Okay, so it's going on over there to the right ventricle, then the pulmonary artery, then, the bubble is in the pulmonary artery. What the fuck is pulmonary? It's lungs. Now, you might think, well, what's the big difference? It's air to air. No, we got a problem with that. The bubble is completely blocking perfusion. So this bubble that traveled from the superior vena cava to the right atrium, through the tricuspid, right ventricle, up into the pulmonary artery, it just stopped all perfusion. It's exactly like a pulmonary embolism, but it's an air bubble. Now, you're not going to do what you did with a pulmonary embolism. With a pulmonary embolism, you had to give the patient oxygen first. You're not going to give air to air. What you're going to do with this patient, and it's hugely important, is you're going to turn them on their left in Trendelenburg. Big deal. Huge. With an air embolism, you're going to turn the patient on their left in Trendelenburg. Now, I just watched a marathon power series. I watched all 3 series in the last week. And 50 Cent got on my damn nerves. However, he's your friend. Because 50 Cent said, head down, ass up. That's what Trendelenburg is. Head down, ass up. You better know that. This patient goes on their left side with their head down, ass up. And that's going to help that bubble move. Honestly, guys, you can't forget this. It's going to help the bubble move. So I had 2 night shift nurses leave Southwest General last night after they got off of work at 7 this morning. Why did they text me? Shell Bell, head down, ass up. We had an air embolism yesterday. I can't stand y'all. Why are you sitting up there with me? My text message at 7:30, head down, ass up. That's what I got. You're going to remember till the day you die the stupid shit we do in this class. They've been nurses now 3 years. They both work in the unit. We got an air embolism last night. Head down, ass up. Oh, okay. You better remember it because that's going to save this patient's life. Now, you can give them oxygen after you turn them on the left with the head down, ass up. You can give them oxygen after that. But you cannot give oxygen before because it's not your priority. The problem with nursing students is they try to give everybody oxygen first. Don't do that. Don't do that on this test. In fact, it's actually kind of maybe not the most important thing on your first nursing action with a lot of people. Kind of because they know you're going to choose it. Don't choose it first unless you really know it's the answer. Okay? All right, guys. That's a big deal. Now, how do we prevent the air embolism in the first place? Well, I wrote down a lot of things. Look what I wrote. Have the patient do a Valsalva during insertion and removal. You might want to know that. Then I also said, if you can't have the patient in Trendelenburg during insertion, then have them exhale. Some people can't be upside down. That's just real. Cannot be putting folks upside down. So if you can't have them, if they can't do that, then they just need to perform a Valsalva maneuver. Remember that most central lines are non-tunneled, which means they're not tunneled inside the body. They're not buried inside the body. You can see the tubes and everything on the outside. Non-tunneled is higher risk for infection. Now, if you look at the Piccs line, I have special instructions there. I have for a Piccs line, just like any other central line, we do confirm with x-ray, right, everybody? We know that's for all central lines. But then some specifics about the Piccs line is I put the law with the LPN and what you can do and can't do, okay? So you have a good one there. That's a big deal. I also put that the Piccs line was good for a whole year. You want to highlight that. I put no risk of pneumothorax. The dressing change is a little different. How often do we change it? Yeah, once a week. Okay. And of course, it's non-tunneled, right? So you're just going to keep remembering that word, non-tunneled. Now, the Hickman. The Hickman is long-term. It's surgically implanted. So is it non-tunneled or tunneled? Tunneled. Please write it. It's buried in the body. You can't see it. You're okay. So typically those are surgically implanted. The triple lumen, non-tunneled or tunneled? Think. You could do it on there, but typically a triple lumen is for something else. But it's non-tunneled because you can see it. You can see all three of the lines, right? The three parts. Now let me show you what typically is going on with this triple lumen, just to kind of put a vision to it. Wonder why I'm spending so much time on this. Wonder why. What could that be about? So with the central line, with the triple lumen, you have some hemodynamic monitoring maybe over here. You have some maybe TPN here. Maybe you can do blood draws here. Okay? Right? You can do a bunch of things. You have a little tube for each one. And then, of course, they all connect into superior vena cava. But you can see those three hanging out, can't you? Okay? Now, this is so nice. The triple lumen, why would I want a triple lumen and not a Piccs? Well, I like triple lumens when I'm going to definitely be giving incompatible drugs. That's when I want a triple lumen. When I know for sure I'm going to be giving incompatible drugs. I would write that. It's the short-term central line. Short-term. It's only going to be in there about a week. Short-term. Portacath or Metaport, they got both names there. Portacath or Metaport, I want you to highlight years. I want you to highlight flush once a month. Tunneled. You see it? Tiny word. I didn't capitalize it. Tunneled. I'm going in order. No exit site is there already. Dressing change not required. Because nothing on the outside. Please know that Uber and non-coring needles are needed for access. So you have to access this with what we call an Uber non-coring needle. A button. You can't see nothing. You can feel it. We've got a lot of people with those. Chemo patients. Yeah. Now, remember, the only way to put it in and the only way to get it out is surgery. Now, let's put a little notes at the bottom of the page for y'all little IV central line kind of behinds. Number 1, no heparin flushes without an order. No heparin flushes without an order. So no heparin flushes without an order. Typically we use normal saline, and we never flush with more than 10 cc's syringe. We don't use a 20 cc syringe to flush nothing. Never more than a 10 cc syringe. Typically it's normal saline. If you are trying to flush the central line with 10 cc's normal saline or with a 10 cc syringe that has normal saline in it and you're having a hard time, have the patient change their position a little bit and retry it. Now, if that doesn't work, if it don't fit, don't force it. Okay, turn the page. The most important thing I can tell you about this TPN that technically would have been nice to put on the same page with the central lines, because it leads you to believe it's a different section. So I want you to put a note there with the TPN, and I don't know how you want to do it, but with really big words, say TPNs are central lines. I still have people in the real world that don't know that. because it's not uncommon to have a patient that gets a TPN on the floors. So you, the floor nurse, can get a lot of patients with a TPN, but you have to remember you have a central line patient. Okay, so we still got to watch it. Okay, now it's probably through a Piccs line, so again it can be deceiving, but it's still a central line. When we look at this TPN, you got 3 labs to follow. Number 1, white blood count because of the increased risk of infection, because TPN solutions have sugar in them, and bacteria love sugar. So you got the white blood cells, it's right there, the labs that you follow. It's all written there. You got your white blood count. You've got albumin. Albumin is a nutrition lab. I tell you, it's just like the meals you should have every day. So we tell you you should have 3 meals plus snacks. What's a normal albumin? 3 plus. 3 what? 3.5. 3, it's more than 3. If it's 3 or less, it's low. So 3 to 5 meals a day, right? So 3 to 5 is normal. 3.5 to 5 is normal. 3 is actually low. 2 point anything is low. And this is a malnutrition lab. Your glucose, don't miss this. Your patient is at risk for HHS or DKA whenever they have a TPN because it's so sugary. It's like syrup, okay? Not really, but it is sugary. So you have to watch their glucose every 6 hours. Now, if you work in the ICU, you know it's every hour because all ICU patients are at risk for HHS or DKA. So, but that's different. This is on the floor. If you're on the floor, patient got a TPN, your minimal amount of time to check a blood sugar is every 6 hours. Okay. Whenever we change dressings on the central line, specifically a TPN, have your patient turn their head away from you changing the dressing. They don't need to be breathing the pneumonia breath over your dressing change. So if my dressing change is right here, and I'm trying to change the dressing, I'm going to have her turn this way. I don't even want her breathing over there. She has a mask on, but I just don't need nothing going over here. Okay, so have them turn their head away from where you're doing it. Okay. Now, when you see it says strict asepsis, it also says all the way down the line, individualized. It's made per person. There's no such thing as going into a supply room and pulling a TPN bag off the shelf. No, no, no. It's made for that person. It's based on their labs. It's specially made for them. It may have insulin, it may have glucose, it may have any number of crazy things inside of it. It's made for the patient, okay? The other thing about that is it's hypertonic. It's a hypertonic solution. There's lots of hypertonic solutions. Dialysis is hypertonic, TPN is hypertonic, all tube feedings are hypertonic. These are hypertonic solutions. Has to be refrigerated. What color should it be? What color should a TPN be? Yellow. Never tan. No brown. Okay, it should be yellow. You can substitute D10W. If it comes up tan and you had to send it back to the pharmacy, grab some D10W because the patient needs it. You can substitute D10W. Okay, now we're done with all our little central lines. Let's do our anesthesia analgesia.